Dr. Musa. Dr. Ziad, such a nice presentation. It's really tough to follow up, but this is my situation. So I'll continue talking about the calcific lesion, giving light in the device choice, and this will be like case-based approach. So this is the picture to put in our mind. We don't want to see this ever in our lab. It's not about how we can push the stent across the lesion, then it looks like this. So it's all about the calcium identification and vessel preparation. So dealing with calcium, it needs 4 steps: assessment, preparation of the lesion, confirmation of the preparation, and optimization of the PCI. So there are many approaches to dealing with calcium, but they all sharing the starting points. This is how we go inside most of the algorithm in the coronary angiography. This type of the severe calcium track on the both sides of the vessels before even contrast injection, this type of calcification which needs special therapy because the invisible or mild calcium maybe can be modified only by balloon-based strategy. So this is a study by a group in Jack. IVUS can detect calcium in around 80% of lesions, OCT in 77%. IVUS is more sensitive. It can see the deep calcium beyond the penetration power of the OCT. Angiography can pick up to only 40%, but this 40% is really important because this type of calcium which lead to stent under expansion. So maybe severe angiography calcium, this is the threshold to use the specific calcium modification therapy. For most of the algorithm, the key points in most of the algorithm is the balloon and crossable lesion. So for the balloon and crossable lesion, it may be the solution here is easy. So this is case number 1. This is around 80-year-old diabetic patient presented with acute coronary syndrome, super tight mid lesion in the RCA. Balloon is not crossing distally. So in this case, I was lucky enough to cross with a microcatheter and switch the wire for a rota wire, then perform the ablation, and this is followed by NC balloon, and this is what I have at the end of the case. Case number 2, this is a different situation when both balloon and microcatheter didn't cross. Patient referred to me after unsuccessful trial because nothing is going distal to the artery. So in this case, maybe we have some solution. In this case, maybe you can try direct crossing with the rota wire distal to the lesion. In this case, I crossed distally with the rota floppy wire. Ablation, atherectomy 1.5 Ber. Shock wave followed that ablation. And this is what we have at the end, 2DES in the lesion, confirmed by intravascular imaging. So here is the rule number 1 for the uncrossable lesion. If you can't cross by the balloon, but you can cross by MC, so go ahead and do atherectomy. But rule number 2, if you couldn't cross by both the balloon and MC, so in this case, try to cross with the rota or Viper wires. Do atherectomy if you succeeded. If you didn't succeed also, try to go ahead and use laser. Other solution, you can increase the support. If you have the CTO experience, you can do the re-entry techniques or even move the cap. Let's talk about the atherectomy devices. This is rotational and orbital. To be honest, for most indicated cases, either rotational or orbital can be used successfully for the lesion preparation. We select between rotational or orbital according to experience, availability, and the cost. For the orbital, for the rota, we know it's coated distally with diamond crystals. It comes in 1.25 up to 2.5, needs 6 to 8 French. It can ablate only forward. This is very important to remember because this can stuck, especially the 1.25 small Ber. For the orbital, the diamond-coated crown, it's eccentrically mounted. It comes only in one size, 1.25 over 6 French guide catheter. It can ablate forward and backwards, and we can increase the ablation diameter by increase the speed from 80 to 120 K. So for the orbital atherectomy, maybe one size fits all. For the lesion, it can give the ultraviolet energy to create vapor bubbles and heat. It comes in 4 sizes. Don't forget to flush during ablation therapy. So the next key point among the algorithm is the balloon crossable lesion. So in this case, if you can cross the lesion with the balloon or the catheter or the imaging catheter, so in this case, we have the chance to study our lesion, to know better about the lesion, the morphology, either it's superficial, deep, concentric, eccentric, or if there is any nodules. And this give us the chance to choose between the modification therapy accordingly. There is some systematic calcium score. We know about the OCT and IVUS. For the OCT, it's called rule of 5. For the IVUS, it's same. OCT, it can detect the calcium thickness, but there is some criticism for these scores because it needs some experience and long training. But the work is still going on to make it even simple. This is the Alterion 2 software from the OCT, from the Abbott. The only thing you need to recognize the orange, then you are experts in recognizing the calcium. The system can tell you about the arc, about the thickness, and about the length of the calcium. And this is very good to detect the calcification. This is the orbital case where a patient, 70-year-old, diabetic, presented with acute coronary syndrome. As you can see here, arc is 360 with calcified nodule. And you can see here, this is LED again with a proximal lesion. So I go ahead and do orbital atherectomy, 120 K, and for the LED, 80 K for the LED, sorry, and 120 for the RCA, because there is a difference diameter between 2 vessels, and this is my final results. What about the limitation? As mentioned by Dr. Ziad, the limitation is the wire bias. As you can see here, if the wire and the burr is the other side of the lesion, then we are not doing anything. We are just creating a hole inside the artery. As you can see here, this is the wire in the other side and the nodule in the other side. So there is no ablation. So other atherectomy limitation, no reflow, hypotension, perforation, and burr entrapment. So this is the IVL. As you can see here, this is the new player in the game and really a game changer. So this is the pulsatile, it gives a pulsatile pressure which create a microfracture in the intima and the media. This is another case was done last week by me and Dr. Musa. As you can see here, there is a tough lesion in the LED. RCA is normal. So we used 1.5 balloon. We create a track for the OCT and IVUS. Again, here we did the ablation, IVL, NC balloon, and this is the final result. We did only drug-coated balloon. In this case, we didn't put a stent in the lesion. So IVL is safe. There is no serious safety issues or complication with the IVL, and this is clear and well reported across the all disrupt studies. And this is actually my very, very short algorithm. Calcified lesions, if the balloon cross distally, yes, I can go ahead and do IVL. If I couldn't cross, this is a good case for the atherectomy. For the calcified nodule, I think Dr. Ziad, he gave light on it. So this is another case, 50 years old, presented with acute coronary syndrome. In this case, we did intravascular imaging, very big artery. That's why we go ahead and use to burr, that followed by IVL. This is the confirmation after the treatment, and this is my final result. So for the calcified nodule, atherectomy and IVL both are an option. Atherectomy, for the tips for the atherectomy device, proper device selection. This is very important because this will affect the response to therapy. Rotatripsy or orbitotripsy can be considered in this case. So in conclusion, this is my last slide. This is how I can select using the modification therapy. For the uncrossable lesion, the option is only go ahead with rota orbital. Laser is another option. Concentric, eccentric, and deep calcium. This is a good cases usually for the IVL as a first option. Nodular calcification, nowadays IVL is a good option to go ahead. Still rota and orbital are an option. For the aorto-ostial lesions, I go ahead and start with rota. IVL also maybe same option in this case. For the under-deployed stent in the current moments, we can go ahead and use IVL and laser. And thank you very much.